Night, everyone.
Oh, I might have clicked a new button. Did something change, Ashley?
I don't see anything changed on the YouTube.
I found a new button that says go live.
Oh, we're live.
Well, oh, that is it. We are in. Let's go. Technology. Are you seeing it?
I see you.
Are we live around the world? We are live.
Oh my
Coming in
gosh.
live. Sorry for the delay, everyone. There's about, oh, we lost Leland. That is unfortunate. All right, he's gone. I don't know. Too many buttons to click here. Welcome in to anybody listening, anybody watching that stuck with us for that 12 minutes. It took me to find the correct button to click. Oh, Leland's coming back. Here we go, Leland. Hello, sir. Can you hear me?
Yeah, I think you ejected me like Dr. Evil or something.
Maybe it wasn't an accident. All right, let's try this again. Welcome, everybody. We are live around the world. Paw Patrol, our first live episode with Dr. Jeff Dykes.
Dr. Leland Jaffe. Good to see you.
Yeah, how are you doing today?
Good. I mean, this is what happens when you get two guys in their almost in their 40s, right? Trying to figure out how to handle YouTube.
I got a couple days left before I turn 40.
That's right.
So
that's right. That's a
gonna
good
cling to that.
milestone.
Yeah, it's not bad. Hey,
Yeah.
listen, I got all the technology. I got this screen going. I got this microphone connected to Riverside, connected to YouTube, connected to the live stream. It's not easy, to be honest with you. There could be an easier way to do this, I bet, because there's like key streams, stream URLs, links. I got to go live here. I got to go live there. And if one is not also
You're
live,
over my head already. You lost me with URL or whatever.
It's over my head, apparently, because I couldn't get it working. So, all right. We are live. Welcome, everybody. Thanks for tuning in. How are you doing, Leland?
Yeah. Good. How's your week going?
Pretty good. I was in the OR today.
Yeah? What'd you guys do?
Did a couple. I like days where I just do like little tiny cases. I don't know why. It just kind of feels like, oh my God, now my dog is stuck in here. Hold on. This is a disaster. Hold on. You left the dog in here.
That would be, it's part of a live show.
She had one job. She had one job.
Yeah. So
not
OR,
really.
Small cases.
I like doing small cases. Let's see. I did a myxoid cyst on a toe with a little unilobe flap. You ever do those where you excise the myxoid cyst? You kind of make an adjacent unilobe and then rotate over. It works super slick.
Mm-hmm.
And then an EPF, and then I did a first MPJ fusion, and then I get in there, and the patient's like, you know what? I think I really want you to fix my hammer toes too.
Ooh.
I was like, okay,
Dreaded
sure.
Hammer toes.
I'd rather not do some hammer toes today. I hate hammer toes. What do you think about hammer toes?
Hammer toes are, probably partially responsible for my receding hairline and gray chin beard here. But hammer toes are interesting. When I was talking to a student today who was able to do a hammer toe on a rotation. And, to me, it's funny because I think of hammer toes as challenging procedures. The bones are small and you're trying to fit little hardware through those bones. And I feel like that surgery usually falls to the least experienced person in the room, where it probably should be the opposite.
Yeah. Be like, you can figure out an ankle fracture. That's easy. One big bone here, the other half of the big bone here, just line them up, and then we're all done here. That part's easy. Little tiny hammer toes. There's an episode of Seinfeld where George runs over a squirrel, and they have to fly in these special tiny little instruments to work on the squirrel. And that's how I feel when I'm doing a hammer toe. Like, we got to fly in the small instruments so I can work on a fourth hammer toe, and God forbid it not be like perfectly straight.
Yeah,
just drives me nuts.
So, I mean, there's a
how do you fix
Seinfeld
your hammer
episode?
toes?
What's that?
No, go ahead. I like talking.
I said there's probably a Seinfeld episode for every experience in life. Larry David's probably a genius.
Do you think younger people still watch Seinfeld?
No,
probably not. I mean, was it on like Netflix or something? Because that's how people watch The Office. I mean, you and I watched The Office when it was on, and now people are like, "Oh, there's a good show called The Office." Yeah,
I've actually never seen The Office.
Yeah, there is. Oh, okay. Bad example for you, but like
I'm talking about like Friends, maybe Friends.
Yeah, shows that are old that people think like a lot of people are into Suits right now. You know, the show Suits.
Yeah.
It was on USA like 10, 15 years ago. And
Yeah,
now
it's an
people are
old
like, oh,
one.
I'm really into Suits. Like, yeah, anyways, they don't realize it's an old show.
Yeah.
Anyway, how do you fix your hammer toes? What do you do? Because I don't have it figured out. I fixed them 25 different ways and I'm never having
Yeah, you know, I've probably gone full circle. So when I first started out, I kept it simple with usually a 0.062 inch K wire and just retrograded out, antegrated in, or antegrated out, vice versa, whatever. But
yeah,
you know, and then I am a sucker for good advertisement. Like, you know, I like the new shiny things when you know, new iPhones start getting um what's it called? Showcased at the Apple event every year. I'm like, ooh, I need that, right? So you
you're
know,
a rep's
some of those new
dream.
fancy hardwares, those internal fixation devices, I've tried them, I've used them, been satisfied with some and disappointed with others, and I've kind of just swung right back to just using a K-wire. And quite honestly, in my experience, if a patient isn't satisfied with a K-wire there for 4 weeks, give or take, then I'm like, probably someone else should do it.
Yeah, I'm inclined to agree with you. So I used to do the same thing. I used to fix with a K-wire and do the little like trick where you slide the Fraser tip over it and you grab it with a coker and you bend it up and then you cut it and then you put the little, what is it called, Jergens ball or something like that. They always had the wrong size. Like, is it yellow? Is it green? Is it whatever? I don't know. We tried to like jam the one on that doesn't fit. Anyways, you end up doing that. And then at that point, the main reason you move away from that is because patients don't like that. They kick something, they bend the wire, it's sticking out. You're worried about infection, but really the bone heals really well. You pull the wire out and you're done. So it's actually better for the patient in the long run and a heck of a lot cheaper.
That's what I was going to say.
pretend
I
to
mean, you're
know
talking
what
pennies on the
those
dollar.
devices cost that they're like, oh, this little tiny, it's probably the same amount of metal, just shaped into a different, little threads on there or something. Same materials cost, but 50,000 times the cost of a K-wire. And it actually turns out to be better for the patient to just put a K-wire in there and say, hey, take it easy for a little bit. Because then you don't have this. Because I've seen everything under the sun break. These little, I won't name brand names, but like these little things that go in there and they screw together, they reverse thread, or they go in I've seen them all break. It's a nightmare.
I mean, those kind of things, whenever I put something in, I think everyone's always taught you got to figure out when you're putting in and how you're going to get it out if you need to. And getting some of those out of the medullary canal of some of those intermediate phalanx and such can be a headache. And then you end up with all this, you know, cavitated bone. You get a medullary canal that's basically void of bone, and it can be a challenge.
I think I've used everything. I've used K-wires. I just do cannulated screws.
Yeah, screws are good too.
I just cross the PIPJ. I just put it in and I try to leave it right near the DIPJ on the off chance I have to try to go fish it out of there. Luckily, I haven't had to take one out yet. But I also have used the little peak implants where you kind of drill, slide one in, and then on the little demo that they show you, just pull the toe, slide it over. It goes. No, like the toe doesn't move like that. You can't pull a toe and like pull it over here and slide it on. So then you end up having to cut it, and then I've broken those. It's just like a nightmare. It's like it should be so easy to fix a hammer toe, but it's the most annoying thing.
Yeah, I got one more funny story about a hammer toe. So I did one case a long time ago with a intermedullary screw, like you talked about, just a guide wire screw, and case went fine, and the patient healed. I actually discharged him. They called me a couple months later and needed to be seen, and not because he was in pain or there was any infection or any problem. He was calling because he said his wife was complaining that he was scratching the wood floors at home. I was like, scratching the wood floors at home? That's really weird. And so sure enough, he comes in and the head of the screw is about a centimeter out the end of the toe, and it's scratching up the floor.
No. And he didn't think that was weird. The wife had to call.
I was like, well, this will be interesting hardware removal.
Oh my God. It's always amazing what people will put up with.
Yeah.
All of you.
Yeah.
Anyways, all right. So what are we going to get into today? We talked about maybe going through a couple cases, talking through some pearls, talking through maybe like some tips and tricks, because I think it's one thing to sit there and we try not to make this a lecture. when we go through our podcasts. It's everyone who would be interested in this for the most part already knows the lecture material. So we're trying to breeze through the lecture material and get to the real world stuff. Okay. I used to make my cut here. Now I don't because of this and the real world implications of doing surgery. And one thing that we're going to talk about today is cavus foot. So I don't know about you, but going back to school, I was always intimidated by cavus foot deformity. I don't really know why, but flat foot always just kind of made sense to me. Like tailor head uncovering. Okay, we're going to swing this. We're going to slide that. We're going to do this. And it just made a whole lot of sense. Cavus foot, although the opposite, always felt way more intimidating because of the neuromuscular component possibility, the whatever is causing it gets a little bit more complicated. What are your thoughts on cavus foot?
Yeah, I mean, I think it's probably less frequently treated or operated on. That's why maybe it's a little bit more elusive.
That's fair.
Most of my patients that I've treated with cavus foot really don't have any neuromuscular condition. It's just more of a congenital, position of how they were born.
Yes.
But certainly can. I mean, I've had my fair share of Charcot-Marie-Tooth patients, and I actually have one right now I'm taking care of. But
those are complicated. When it becomes a progressive deformity, I mean, it just gets so much more complicated. And we'll talk about the difference between progressive versus static cavus foot deformities, but I think that gets so much more complicated in a hurry.
Yeah. I mean, for those listening, I mean, I teach at school a lecture on Charcot-Marie-Tooth, and the way I really frame that discussion, and what's always made it simple in my mind, is really thinking about it as a tendon balancing, right? Agonist and antagonist muscle groups. And that's always made it easy for me and really helped me remember too, like what tendon transfers you should be considering, because those tendons are usually still viable, or especially in a progressive neuromuscular condition like CMT. But like, for example, with cavus foot, we usually see a plantar first ray, right? So what tendon's pulling that down? The peroneus longus usually. So maybe we can cut that and tenodece that to the peroneus brevis, who's getting overpowered by the tibialis posterior. So I always kind of think of it as like an antagonist agonist muscle group, and it's always made sense in that fashion to me.
Yeah, I think if you break it down, each kind of procedure for one has the opposite procedure in the other, and that's kind of what you're talking about. Now, I would probably take tendon transfers and kind of set them aside for a minute, but if you're just going to break down, the opposite of an Evans is a Dwyer. The opposite of a medial calc slide is a lateral calc slide. And the opposite of a Cotton is a DFWO, dorsiflexor wedge osteotomy, even though it's in the first metatarsal as opposed to the cuneiform. But each procedure has kind of the either or I should say the opposite of each other. And when you start thinking about it that way, I don't think it's overly complicated. So let me share this here and see if we can get this to pop up.
Yeah. While we're waiting, one thing that we talked about a bit was in my residency training too, like a lot of our chronic ankle instability patients, a lot of them have a cavus foot or some type of rear foot varus position. Are you sliding the calcaneus laterally or doing a Dwyer in those types of feet that just have that chronic ATFL type injury?
No, but Dr. Strasser and I talked about that quite a bit on our podcast of trying to figure out, okay, if someone has a peroneal tendon injury with plus or minus lateral ankle instability, but mainly we're diving into peroneal tendon repair, and it's secondary to cavus foot deformity, should we be doing a Dwyer or a lateral calc slide? And I think that's a really interesting thought that I really have never done. And I do tons of call it scope rostrum peroneal. I do, scope rostrum peroneal procedures all the time. And I guess my answer would be, well, my answer is no, I don't do it. And I guess based on how well people do, I would say that we don't need to do that, because I feel like there'd be a large number of people coming back and saying like, it's just still hurts.
Right. The recurrence issue would be a problem.
But I think it's a reasonable thing to think about. And I might, you know what I need to do? I need to be better at taking calc axials and evaluating the actual varus deformity. Because what I do, I get lazy sometimes and I just look at the patient's foot and I look at the lateral, and you can see, once we jump into this, you can see the lateral, and you're like, straight away, you're like, yep, cavus foot, boom, cavus. Okay, here's what we're going to do. We're going to do this, this, and this. But I think maybe in those lateral ankle instability patients, I'm focusing so much on, oh, you got an MRI, we got the peroneal tendon pathology, we need to fix your peroneal tendon. I'm going to fix the ligaments to protect the peroneal tendon repair. Might as well scope your ankle while we're in there. But I think if I got a calc axial, so you're triggering me to think about maybe doing that a little bit differently.
Yeah, no, I think intuitively it makes sense, but it's just more surgery, it's more fixation, it's more recovery for the patient, more risk. So
Yeah,
hard,
but it's a
I don't know.
pretty. I've started doing some MIS calcaneal osteotomies, and I've done quite a bit of MIS. It is dang hard to make a straight cut with a burr that's going like, so like
Down the
zigzagging all over the
posterior tuber of
place.
the calcaneus.
Yeah, and you're trying to like keep it so straight, and then you drop your hand, it goes forward or backwards. I did a like a Zadig. I
Mhm.
still don't even know how to say it, Zadig or Zadig. Osteotomy in the calcaneus the other day with an MIS burr. Just made like a tiny little incision, just stuck it in
Right.
there. And I got the wedge out. I mean, it took forever. I kept jacking up the RPM and changing the
Mhm.
burrs out. And eventually I got it. But the osteotomy was like kind of zigzaggy. And I don't know, it's
Good news.
difficult. So I was
Good
thinking
news.
of adding, a Dwyer or some or like a calc slide or something in these patients. If you could just do it with an MIS, maybe people who are better than me can do that easily.
Yeah, that it is tough. I have not done that on a patient. I've done it in a cadaveric specimen in a lab,
Yeah,
and it was tough.
yeah,
I think it looks simple,
very
but
much
definitely
so.
there's a learning curve. I
It's
would
kind of
definitely hit
like
the lab and the get in the reps before you do that on a real patient.
arthroscopy. I can feel people looking over my shoulder like, that's what's he doing? Why is it? And then you're like, here you go. And they're like, oh, this is, I let the students play around with it. They're like, oh, this is hard. I'm like, yeah. And I
Mhm.
did all the hard work. I got in there, got it all opened up, cleared out all the junk so you can actually see what's going on. But
Mhm.
yeah, some things look a lot easier than they are. And I think the MIS burr making
100%.
a straight cut is one of those. So this is a case that I did. And again, we're just going to try to focus on the kind of the clinical implications, but you can't really talk about the clinical implications and the thought process without understanding some of the book type things. So we'll kind of try to gloss over some of the lecture type things and really focus on the practical application. But this is a young girl that came to me with bilateral foot pain. Clear as day, you can see here on the lateral that she has cavus foot deformity. But a lot of times they'll complain of that midfoot osseous prominence right at the first tarsal metatarsal.
Mhm.
You see that quite a bit. Her feet were getting tired. And then we have to evaluate, okay, what's causing this? Is this just a congenital deformity or is there something else going on? CMT, spina bifida, CP, muscular dystrophy. Obviously, in a 19-year-old, a stroke would be unlikely, but keep it on the list for some older patients. But what are your first thoughts when you see a patient with cavus foot deformity?
Yeah, I mean, certainly treating the patient, not the X-ray. I think X-ray we can look at something like this and salivate with all the different cuts and things that we can do to fix it, but really look into patient, talking about what their goals are. Yeah, are they an athlete? Are they
Yeah.
what are they trying to achieve, right? And can this
Right.
be accommodated non-surgically first? Anytime you
Yep.
operate and reconstruct someone's foot, you really are married to them for, I don't know, 6-12 months of recovery and rehab and PT. It's a commitment. So
Sometimes
that's
forever.
usually the first conversation I'm having is really just, what are your goals? What do you want to achieve?
Yeah. So we're going to evaluate. And the main way we do that, again, the book stuff, literally sometimes a textbook, you pop out a textbook and do the Coleman block test. And we're trying to figure
Yeah,
out, is
don't
it
forget that
forefoot or
one.
rear foot driven? What's that?
Yeah, that's one you can't forget. That's a board's question every 10 out of 10 times.
Yeah, exactly. So then we have to figure out, okay, is there a flexible deformity? Are we going to reconstruct it with osteotomies, potentially tendon transfers, or is it rigid deformity? If it's a progressive deformity like CMT, well, then you're probably not going to want to do certain things because it's going to be progressive and you're going to recreate a normal foot and then it's just going to progressively get worse. So you're tending more towards like fusions as opposed to osteotomies if it's a progressive deformity. So when we get into procedure selection, or let's look at that x-ray first. So pretty classically, the
Hmm.
things that I see there, and I try to teach the students that there's some pretty classic things that you can see on a lateral x-ray. Posteriorly rotated fibula, the double density sign of the talus. So when you look at a lateral, the talus should look like it has one arc to it, which means you're looking at the medial shoulder and the lateral shoulder superimposed on each other, and it's just making one arc. If you see both sides, it means that there's rotation of the talus one way or the other. Bullet hole sign, which is opening up at that kind of facet between the subtalar joint, and increased calcaneal inclination angle. So usually you'll see all of those go together. And when you do, it's classic cavus foot deformity. Any thoughts on that?
Mm-hmm. Yeah, no, I think all those are good. In terms of the forefoot too, I'm looking at the Meary's line too, the talus to the first metatarsal. Again, usually you're going to see a plantar flexed first ray with a kind of a forefoot valgus type position in a cavus foot. So
that's the tricky part sometimes, is when they don't have a plantar flex first ray, but they have significant hindfoot deformity. Do you still include some sort of first ray correction? Because, even if it's not driven by the forefoot, you have to potentially include some procedure selection for the first ray, even if it doesn't have that classic angulated plantar flex first ray compared to the second metatarsal.
Yeah, I think that's something that you can anticipate maybe with your physical exam, your Coleman block test, again, seeing if it's a forefoot or rear foot driven cavus, and then, consent the patient for it. And then once you correct the rear foot and do your tendon release in terms of your gastroc and such, then you can really reassess the forefoot to rear foot alignment and see if you're happy.
So what are your thoughts on gastroc recession and cavus foot correction? Because I don't typically do it. I think in my mind, I've been so ingrained with flat foot deformity, gastroc recession, or hindfoot, whether it be a gastroc or a TAL, whatever, but some sort of posterior muscle group lengthening procedure. And I don't typically think about it when I do cavus foot reconstructions. What are your thoughts on gastrocs for cavus foot deformity? Because there's some thought that if they have some amount of gastroc equinus, that it's causing overexertion of the peroneus longus, which is plantar flexing the first ray, which is driving the cavus foot deformity. So we need to release the gastroc equinus. I mean, it's simple enough to just check for equinus, do silver squad school test and check for that. But what are your thoughts on, do you typically think about gastroc?
Yeah, no, I agree. And I think a lot of the equinus we know in cavus is due to that pseudo equinus. More so, you're kind of using up that equinus for getting that heel to the ground as opposed to actual decrease in ankle joint motion. But really, again, just based on your physical examination and if it's a true equinus, I think it should be addressed. I think if you release the gastroc, transposing and moving the posterior tuber is usually going to be a little bit easier too in terms of the calcaneal osteotomy.
What do you favor for your gastroc recessions? So if I put on there endoscopic, like small open, like a Bauman or a Strayer or a TAL, what do you do?
So it depends. TALs, the percutaneous TALs, I will do a lot of times, perhaps in a diabetic foot, or if I'm trying to offload a forefoot wound or something like that. But if I'm doing something like this and I'm just trying to address perhaps just the gastroc, shout out to Dr. Grambard. That's where I did most of my training in terms of gastrocs. I did a ton with him, and we did those Bowman procedures. So I like the mini open right at the muscle belly, releasing either the gastroc and or soleal aponeurosis intramuscular. I think it's just a safe area. You can really get a nice release up there too with minimal morbidity.
I agree with you. I do an endoscopic. It's just my preference and I'll tell you why here in a minute, but I think the Bauman probably makes the most sense because, like you said, you have direct visualization. Sometimes you have to bust out the super long scalpel blade and the pediatric speculum and get some side glances of what you're doing. But you put that in there and you can get direct visualization of both the aponeurosis on the gastroc and the soleus. You do one, if it's not quite enough, you can do the other. Kind of leaves you open. So I did have a few patients a couple times have this big dell in there because I don't think I was just releasing and stitching up like, oh yeah, you're good. But you have to oppose or repair. Yeah, the deep fascial layer. Otherwise, they'll get this kind of like dimple in the medial side of their calf. Like, what's this? Like, oh, I don't know. I think that'll go away for you, and it did, but it kind of was a little silly. So, I prefer the endoscopic gastroc. I can just make those two incisions go across and be really quick with it. But I do not favor the TAL. I think you're playing with fire a little bit there, unless it's a diabetic and they just have. I did a gastroc one time on this kind of uncontrolled diabetic, and it did not go anywhere. It literally just was like nothing. So then I did a TAL, and it worked fine.
And I think a lot of that's you get so much of that glycosylation of collagen and tendon, and so much contracture there that if you release proximally, I'm just underwhelmed with how much correction I get in the diabetic foot. Especially, I'm really trying to offload that forefoot. So,
and I don't do a ton of that stuff, so I was kind of caught off guard. I did it, and on mobile, I was like, nothing happened. So I had to jump to a TAL on the fly.
Yeah, TAL is on when you're doing a Hoke or a triple hemisection. The first time you do it, for those that haven't done it, the first time's a little nerve wracking because you dorsiflex the foot like gently, and all of a sudden you feel it slide, and you're like, oh my gosh.
Yeah.
Like ripping celery.
It really is. That's a good way to describe it. Okay, so on this patient, I thought about doing a Dwyer osteotomy and a dorsiflexor reverse ray. What is your decision making between doing like a Dwyer or a calc slide? And then I'll tell you my thoughts.
Yeah, really just experience and comfort level. To me, again, I think you can look at your calcaneal axial too and really see how much varus position the heel's in. I think that will help you out.
Yeah, that's fair. That's
fair. I think doing a lateral slide is technically easier.
Sure.
I think that you are, moving the insertional point of the Achilles laterally, so it's turning it a little bit more into a pronator than a supinator. So I like that. Putting that ground reactive forces right, back under the tibia. So I'll kind of lean that way, more from a ease of procedure. And
so my thoughts are that a calc slide is kind of a less aggressive procedure. So if they don't have that, like you said, if on the calc axial you don't see that true varus curvature, I think you can get away with a calc slide as being kind of an intermediate procedure. It's powerful, but it's not as reconstructive, or I don't know the right word, but
I was gonna say, it's not as corrective.
Yeah, it's not as powerful as like a Dwyer or an Evans in a flat foot. Same thought process being calc slide versus Evans in a flat foot. And so I think I view them as kind of step one and step two, calc slide, and then either the Evans or the Dwyer flat foot, Cavus foot from that standpoint. So I decided to do a Dwyer and first ray procedure as well. So when we look here at doing the Dwyer, you saw on the previous slide kind of where we make our incision there. And so this can be a little tricky, and we'll talk about here in a minute with some research articles about talking about where to make the cut, the angle to make the cut, and how much of a wedge to take out of there, because I think that's good knowledge to have. Ideally, try to keep the medial cortex intact. We talk about, like a green stick fracture, where part of the cortex is still intact. But in this case, if you can keep the medial cortex intact, then it's going to be easier to maintain that posterior tuber. Now, you could make an argument that you can maybe do like a Dwyer calc slide combo. If you do violate the medial cortex, you can get a little slide out of it as well. And that's fine. I don't typically do that, but you could. But the risk of violating the medial cortex is that you're going to get proximal translation of the posterior tuber. It's going to want to slide up on you because the Achilles has a strong pull. It's going to want to pull up and cause deviation of your fixation. So this is the wedge here, and then wedged out, and then showing that the medial cortex is intact and getting closure there. Any thoughts on this?
No, I'm just, my eyes are fixated on you reducing that Dwyer like 20 times in a row now.
It's looping. Don't worry. It's not a 20-minute video of me sitting there just continuously.
I was like, man, I think you got it. I think you got it.
Like, nope, keep filming, go, keep it going, keep it running. We're going to go 20 more minutes of Dwyer closure.
No.
All right. So this is an interesting article. So it's much better if people watch, but people like to listen. I get it. So it's called Effects of Variations in Dwyer Calcaneal Osteotomy Determined by Three-Dimensional Printed Patient-Specific Modeling. It's a mouthful. Journal of Orthopedic Research, 2020. So what they did, these are my x-rays on the bottom, not theirs. So
Mm-hmm.
they wouldn't take credit for this. They'd be like, that looks terrible. But those are my x-rays on the bottom. Those are two different patients. You can look at the angle of the osteotomy and see that they're two different patients. But we'll get to those here in a second. So basically what they did is they looked at the angle of the Dwyer cut and how much they took out, either 5 millimeters or 10 millimeters of the wedge. And looked at the amount of correction that they were able to obtain with the cut and to see which of those actually mattered. So common sense is this first line that says significantly more correction with 10 millimeters compared to 5 millimeters. So I shoot for, I've always thought about 7 to 10 millimeters, and I usually shoot for marking out about 8 or so millimeters when I mark it out and draw my little marks on the calcaneus with a ruler, because you know that the saw blade is going to take a little bit on each side as well.
Mm-hmm.
You can always take more. You can't really take less. So if you get in there and you take too much, well, that stinks because you can't go backwards. But if you take not enough, then you can always feather it. You can kind of close that wedge down, stick the blade in there. You know I'm talking about feathering with the saw blade. If anyone doesn't know what that means, basically you're pushing the osteotomy close with the blade in there, and the blade is then kind of resecting right in line with the osteotomy site. They also found that there was no statistical significance between a 30-degree cut or a 45-degree cut. So the angle of the cut, you can see here I have two different cuts. The picture on the left and the middle are the same patient, and that's more of kind of a 45-degree cut, I'd say. Mm-hmm. And then the one on the far right is a more vertically oriented osteotomy, and they found no significant difference between those two, which I guess makes sense. I mean, it's hard to thinking about a 3D model of trying to make. I think that's probably why they did the study, because it's hard for your brain to try to make sense of whether the angle of the cut would make sense or not. But they found that it did not. They also found out that the distance from the posterior calcaneal tuberosity did not matter. Now, there's a safe zone in the calcaneus. You don't want to be too far posterior or too far anterior. But I kind of shoot for that kind of mid substance of the posterior tuber. What are you looking at, or what are you thinking about with your orientation or placement of a calc osteotomy?
Yeah, same position. I'm going maybe I don't know, centimeter and a half or 2 centimeters posterior to that posterior facet dorsally, and then angulating about 45 degrees to the weight bearing surface.
Sure.
Yeah,
it seems to work pretty well. And they said that a 45-degree cut did result in less calcaneal shortening compared to the 30-degree cut. So I guess if you were going to pick the ideal Dwyer, it would be 1 centimeter of bone, 45-degree angle in the safe zone, which is what you just said. And I think that's what most people do, but it's kind of nice to have some verification of that. In our world and most medical worlds, I would imagine, sometimes there's things that we just do because, why do we do that? Well, I don't know. That's just the way it's always been done. But it's nice for someone to come along and be like, well, could we do it better? Or is there a different way to do it? Or why do we do it the way that we do it?
Yeah. Well, I think the good information coming out of the article is essentially that on an X-ray, it looks easy to hold up a ruler and to really measure the actual angle, but intraoperatively, it can be a little tough to identify what's 30 degrees, what's 45 degrees, right? Even if you have a good true lateral, that cut can be a little bit tricky lining it up. So good news, you can have a few degrees of error in that cut in terms of between 30 and 45 without an impact on your outcome.
It can be quite complicated because it's a 3-dimensional object. An X-ray is a 2-dimensional object. You can draw a straight line.
And you're trying to meet at an apex, right?
Exactly.
It's tricky. Yeah,
exactly. It's actually quite difficult, and you're kind of on the side. And then when you're sitting there laterally, it's hard to get a lateral X-ray because that's where the X-ray machine wants to be. So then you're kind of like scooting to the side, and then trying to cut with the X-ray, getting a picture in there, and you're cutting from the front. So I think there's quite a few things like that. They're a little trickier than people think that they're going to be, because when you look at an X-ray, it just seems so simple.
Yeah.
So dorsiflexury wedge osteotomy here, kind of make it near the base of the first metatarsal. Take out your little wedge there, put your plate on it. It's fairly straightforward. We won't spend a whole lot of time on that.
I mean, Yeah, and these are great. Easy procedure. Ground reactive forces are actually reducing your osteotomy, they're compressing it, I should say, not distracting it. So definitely a good procedure to do for this.
I do like a cotton better because a cotton is literally just making a cut and sticking a wedge in there and you're done.
Yeah.
I mean, it's so slick.
Going back a little bit, do you consider doing a plantar fascial release in these patients?
No.
Okay.
Not necessarily. It's a good thought. Kind of like what do we talk about? Doing a Dwyer in a perineal tendon repair or something like that. That's why we talk about these things, because I think it's important to not just do something the same way forever. I don't know. What are your thoughts on that? I mean, I haven't had issues with that, but it certainly makes sense that it could cause issues.
Yeah, not necessarily because someone's having heel pain, just more to help reduce your deformity.
Yeah, I mean, it makes a lot of sense, and it's simple. You're already there. You're already doing surgery, and it's a straightforward procedure. So, makes a lot of sense. Okay, so we went through that, and we have a cavus foot correction there. So, what are your thoughts on? I try to not reconstruct people, especially she's 19 years old. She has bilateral foot pain. So this is one where I must have done a good enough job because she came back and wanted the other side done. And I've talked about that before, how I absolutely hate that, because now all the pressure's on to do the exact same thing in the exact same way with the exact same success rate. And sorry, the pressure's on. What are your thoughts on any of that stuff? Cavus foot, or doing bilateral procedures, or patient coming back to you and wanting you to do the other side?
I think that's probably the best compliment you can get. Um, I'm very hesitant to doing bilateral cases in the same setting, because then inevitably I think they're going to heal at a different rate, and they're going to be one side inevitably is going to be undercorrected compared to the other side, more painful than the other side. So I don't like doing bilateral cases in the same setting if I can avoid it. But if they come back for the other side, I think that's a good compliment.
Yeah. All right. Should we wrap up cavus foot here? So Dwyer angle, 45 degrees, 1 centimeter, safe zone of the calcaneus. I do 2 cannulated 6-5 screws oriented from posterior to anterior. I do not necessarily love any hardware placed laterally along the calcaneus. I just feel like if you take your finger, everyone do it with me, put your finger down on the lateral side of your calcaneus. There's no meat there. There's no muscular coverage. There's nothing there. Any kind of hardware has the potential for causing irritation.
Especially if you're doing a lateral slide and you have that shelf, then you've got a lot of tenting and tension laterally.
Yeah, I'm not a huge fan of lateral hardware, even though it seems to make sense because you're literally staring at it. I just made my osteotomy. I pulled my wedge. I'm staring at it. Let me put a little something on there. I mean, maybe if you put a staple or two, a little low profile something, a little X plate that sits down pretty close to the bone. But I just have good success throwing those 2K wires from posterior to anterior up through the calcaneus and letting that be my fixation.
You mean even like in a pediatric, when you have a growth plate, instead of doing a step off plate, you'll just drive some K wires and keep it temporary?
No, that's going to be different, obviously. So if there's growth plate concern, I mean, honestly, in kids, I do everything in my power not to do reconstructive surgery in children. I just am of the belief that they're still growing. Things are going to change. What if they grow out of it? What if it stops hurting? What if? And I've gone in there and done all this reconstructive surgery, and I just, it may or may not be the right thought process. I don't see a lot of reconstructive kid stuff. I see a lot of pediatric trauma, and so that's different.
Right.
But reconstructive stuff, I try so hard. I'll do bracing, I'll do inserts, I'll do whatever I can to not do any reconstructive surgery.
Yep. That's a whole other conversation.
Yeah, it is. Well, you started it with the growth plates and all that. I didn't want to talk growth plates. I'm just kidding. All right, so let's talk here at the last part of our Paw Patrol Live, talking about ankle fractures. So This is an 82-year-old female with osteopenia, ground level fall, bimal ankle fracture. And so these are a little bit tricky. And we've talked in many episodes before about trying to evaluate the patient separately from the x-ray. And so you look at this x-ray and you're like, it doesn't look too bad. I can't even see the fractures. Where are the fractures? Well, anyone watching, there's a transverse medial mal fracture here. You can see that the cortical line at the medial gutter stops here and picks up again here. So you have a transverse medial mal fracture, and then we see lateral step off of the cortex of the distal fibula here. So we know that there's a transverse. I shouldn't even call it a transverse. We have a distal fibula fracture here and a transverse medial mal fracture here. So by nature, we have an unstable fracture because it's bimalleolar in an old patient with osteopenia. What are your thoughts when you see this x-ray? Because I think there are some people who would make the argument that it's minimally displaced and you could potentially not do surgery. I am not of that belief, but there might be some people that would say that. What are your thoughts?
Yeah. So my first thought is, when you're dealing with an 82-year-old patient, are they physiologically older, younger, right? So what is their, again, kind of going back to what is their pre-injury activity level? Are they a home ambulator, community ambulator, non-ambulator? Do they what are they trying to achieve, right? And if they're just trying to walk again comfortably and not be in pain, then something like this needs to be fixed. This is going to go on to lead to the instability and complications. And so if the goal at least is to become a home ambulator around the house, this needs to be fixed.
I've yet to see an 82-year-old fly into my clinic on crutches. Like, it just doesn't happen. I mean, hopefully my dad doesn't break his ankle, but my dad still plays tennis. He's in his 80s and he still plays tennis 3 times a week, and he's out there just doing whatever he wants. Maybe he could use crutches, but the average 82-year-old patient, go ahead.
Yeah, I was gonna say my parents have downsized to pickleball from tennis.
Yeah, he won't do it. He played college tennis, so when you play high school and college tennis and played tennis your whole life, he's not going to switch.
Good for him.
Yeah. So anyways, him aside, I don't see these patients, flying into the clinic on crutches. So you think, put them in a cast. Oh, okay. Well, now what? Wheelchair? Yeah. Okay. Now they're bed bound and bed sore. Like, it just gets into this whole thing of the surgery you select has so many downstream ramifications. Okay, well, you did this. Well, now they have to go to a nursing home because they can't put pressure on it, and they can't be home by themselves, and they can't, or their significant other who's also in their 80s can't take care of them. I mean, it's so many things to think about. So I've been doing this long enough now that those are all things that you don't really think about when you're in school. You just look at the x-ray and you're like, I would do this, this, and this. And then you see enough people and you're like, no, don't do that. We got to go in a different direction because of this, this, and this.
Yeah. And this reminds me of a conversation we had when we were talking about Jones fractures on the 5th metatarsal in terms of surgery, non-surgery. And this is a situation where surgery might be the least invasive way to treat the patient. Meaning if you put this patient in a cast for 4 weeks, that probably has, and you try to keep them non-weight bearing, your risk, I think, is going to be much greater than putting them under anesthesia for a short case to stabilize this.
I agree with you. So we've got the bimalleolar fracture components here that we just talked about. Jumping ahead. Okay, so this is something that I want to dive deeper on, and anyone watching can appreciate this, and anyone listening, picture it in your head, I guess, or watch the video. So when you look at this x-ray here, the pink line is the continuation of what should be the medial cortex of the medial malleolus at the medial gutter. So you can see where the white line of the actual bone is and where the continuation of the medial malleolar cortex should continue down. So by nature, if you ignore where this bone is, you'd look at the gap between where the talus is medially, the talar shoulder medially, and where the extension of the medial cortex should be. We have increased medial clear space. We don't actually have medial clear space because the piece of the medial malleolus has translated laterally, so it doesn't look like increased medial clear space. But if you break it down like this, you have effective medial clear space increase. So that means you have lateral translation of the talus. So you have distal fibula fracture. We know talus follows fibula. Talus moves laterally. You have instability. Ramsey and Hamilton, 1 millimeter of lateral talar translation is 42, 43, don't remember percent of decreased tibio-talar contact and then instability. So that's why this simple fracture is all of a sudden not quite as simple as it used to be. What are your thoughts on that?
Yeah, I think it's a great explanation because the way you draw it out, and I would encourage people to go and watch the illustration because, yeah, you could be to the untrained eye, it looks like, yeah, that gutter is less than 4 millimeters. It's not, there's no widening, so really no problem. But yeah, when you extend out the cortex with the tibial plafond, you can definitely tell that there's a step off.
Yeah. And then the lateral step off or lateral translation of the distal fibular fracture as well. So those are things to think about so I think it's important to be able to critically analyze an x-ray like this and understand what you're looking at, because effectively it changes potentially what your treatment might be.
Yeah. Yeah, because I mean, if you look at that X-ray, sorry to go back, well, you can keep it on this one.
Yeah.
We might look at the tibiofibular clear space or the tibiofibular overlap, and everything looks, without measuring it, that it's probably within normal range here. So alignment might look normal. But yeah, I agree. But it kind of goes back to understanding just basic, stability and instability. If you have two breaks in the chain or two, bimalleolar type involvement, this is not stable.
Yeah, I've never really gotten on board with the thought of, I think sometimes surgeons will look at an x-ray and say, how about this? Let me put it a different way. I think if you showed certain surgeons an x-ray, they would say one thing, and then if you told them, well, that's actually your mother, now how are you going to treat it? They'd be like, oh, well, I would do that. If you shouldn't change what your treatment option would be, meaning that some people are like, oh, well, the medial, yeah, that'll be fine, that'll heal. Oh yeah, that'll heal, that'll be fine, that'll be fine. Whereas then if it's a loved one, oh, that's your sister or brother, oh no, we gotta put that back together, we gotta make that perfect. Well, isn't it fair to this person to make it perfect as well? Not that you can make every fracture perfect, that's not what I'm saying, and not every patient is a good surgical candidate, obviously. But I don't like the idea that sometimes people will get a little lazy and think, oh, that'll be okay, and not think about making it as good as it could be if it was one of their loved ones. Stunned silence.
Yeah.
Are you in stunned silence?
No. It's assuming you got a good relationship with your mother, right? What?
Well, that's true. That's true. That's true. You might be like, mom will be fine. Yeah.
Yeah, exactly.
She'll walk in circles for life, but she'll be fine. one will be shorter than the other. She'll walk in circles, but
that's funny. It reminds me of for not going too far off topic, but for like deep-seated interdigital like haloma males, I like to do a syndactylization.
Yeah.
So I always like warn my patients, you're not going to be like swimming in circles with a webbed, foot.
They might get good at swimming. They might want to do the other side. Do them all.
Yeah, that's right.
Yeah. All right. So we're looking here and we're talking about non-op versus operative. We already talked about unstable bimal, elderly patient, cast to crutches. Is that going to result in a fall? I've had people even fall off of knee scooters, and you think knee scooters are, they're going to be fine, way safer than crutches. And everyone thinks that they can remain not everyone, shouldn't say that. I have quite a few patients who think that they can remain non-weight bearing with a walker. I do not subscribe to that. What are your thoughts on letting someone be quote unquote non-weight bearing with a walker?
That's tough.
Very tough. It's tough for a young athletic person to hop along, let alone these elderly people. Oh, I have a walker. That's not going to cut it.
Yeah, a walking cast, for sure. Sure. I have a lot of patients with like total contact casts that use walkers, but Yeah, to non-weight bear on that requires a little bit of agility and coordination.
Yeah.
And strength.
Yeah. So I'm not a big fan of that. I mean, so I tell people, crutches if they're younger, knee scooter if they're middle aged,
Yeah.
and older people
Wheelchair.
wheelchair. Yeah.
Yeah.
Sucks, but that just is the nature of it. And so if
Right.
those are your options and you're potentially going to tell someone to do something that could lead to a fall, God forbid they break a hip, a wrist, separate their shoulder. I don't know. Anything can happen. And so then you start thinking, okay, well, what are the benefits of jumping ahead to surgery? So we have some incisional risks. So is the incision going to heal? Delayed healing. Okay, do they have diabetes? Do they have old age? They have venous insufficiency. Sometimes you see these patients, they have that paper, that tissue paper skin where you're like, oh, this is just, oh man, this is going to be tough to get it to heal. And then thinking about when are we going to let them weight bear with non-operative versus operative treatment. And for me, that changes quite a bit. If I have metal across the fracture, I'm going to let them weight bear a lot sooner than if they have no metal and they're at risk for displacement and ending up with, compound fracture.
100% agree. Yeah.
We got a shout out from Jim McDonald in the YouTube chat. Yeah, future guest Jim McDonald. How you doing, Jim? Thanks for joining us tonight on the YouTube live Paw Patrol. We look forward to him on the Paw Patrol coming up soon as a guest.
Yeah, 100%.
All right, this is the actual insertion of the fibular nail. So in this case, I think it's going to loop, so I'm going to talk for a minute. We won't miss it. We
have a 6-minute case.
Oh
no, that was your Jones.
Yeah, and it was 5. So if you could actually spread the correct information, that would be fantastic. 5 minutes, 53 second Jones fracture. Okay, I still never heard from anyone. Oh, you know what? That episode hasn't released yet. So.
All right. Oh, nice. Okay, fair enough.
I was like, I never heard from. All right. So this is, yeah, exactly. More to come. Jones fractures releasing soon. So we are okay. So we throw the wire and then we drill. So the wire, just like any case where you're going to have a wire guide the procedure. I'm thinking of a Jones fracture. We talked about that on the procedure on that episode, where the wire essentially is the case. You throw the wire, okay, we're pretty much done here. The rest is just stepwise approach. You get the wire in the correct place. So in this case, let me go back. For anyone who's watching, I want my wire starting point to be right here, because very similar to the 5th metatarsal, there's curvature, just anatomic bowing of the bone. If you drew out on a map, this starting point here at the very distal tip of the fibula, it's going to be very different from the central aspect of the fibula here and the central aspect of the fibula here. That is not going to form a straight line to go from here all the way up. Now, there is a little bit of lateral deviation of the nail to accommodate that. So if your wire does bend, that's normal and expected to follow the medullary canal. But you don't want to start too far laterally. That's not a good starting point. So we should also talk about reduction of these fractures, and we'll get to there in a minute. Let's talk about technique and tips for putting in the fibular nail, and then we'll talk about things that I could have done better in the past because nobody taught me how to do this because they weren't available. So it's just me teaching myself on the fly, and then I can teach you guys about what to do and what not to do. So the starting placement for this wire is about the central aspect of the distal fibula, not quite hugging the talus, but not far off, and then trying to hug up through the central medullary canal. If you put the K-wire driver, pull both triggers, it's going to oscillate. If you pull one trigger, it's either going to go forward or backwards. But if that's the case, then the wire has the possibility of penetrating through the cortical bone. It's going to go from the medullary canal out, usually medially, because the wire wants to go this way, wants to stay straight as opposed to bending up the medullary canal. But if you pull both triggers, it goes on oscillate. You throw the wire up the central aspect of the fibula, and the case is pretty much done at that point. So I wanted to talk about wire starting placement, because then you do the drill and then you insert the fibular nail on this jig. So one thing that's not really appreciated is that when you have the nail in, that jig will move it can move anteriorly, it can move posteriorly. And so what wants to happen, you can see here how the jig wants to be pushed anteriorly by the bed. So it's not a horrible idea to have the foot offloaded a little bit off the edge of the bed so that that jig is not resting against the bed, because you can see the bed wants to then push and tilt the jig anteriorly. And that will change the orientation of your screw. So if the jig rotates anteriorly, then the nail is rotating anteriorly, and your crossing screw is not really going to be a problem. But where I've run into issues with it is if the jig rotates anteriorly, the nail rotates anteriorly, and I'm throwing my syndesmotic fixation, all of a sudden my syndesmotic fixation is not at the correct angle. It'll still go in. It's a jig. It's going to find the correct hole. It's going to go through the nail, but all of a sudden it's going into the tibia at a much different angle than would be optimal. So pay attention to keeping this jig, and this is just one specific product. There's lots of fibular nails out there, but keeping the jig straight lateral, not letting the bed rotate the jig anteriorly. Jim's tuning in from Montreal. This is international. Can you believe that?
We are an international podcast. In Canada. I know, Jim. You left for a year, right? I think I don't know if we can talk live here, but I know he moved away from Canada for a while, or took a sabbatical, came back.
I don't know.
Yeah, I didn't talk to him again.
We'll talk to him on the podcast. We'll get all the deets on the podcast.
Yeah, we need to be back up to speed here.
Yeah, for sure. All right, so we've got the nail in, then we're taking the jig off. And then you're looking on the right video, the incisions that were required to place the fibular nail, the cross-locking screws, the syndesmotic fixation system, we'll call it. And I think this one had a medial mal. I think I did a single medial mal screw.
Yeah, it's percutaneous.
Yeah, so small incisions that you're able to fix that through. So in this case, I felt it was the best option for this patient to do minimally invasive fracture repair and get them walking right away. I tend to skew that way when you have an elderly patient with an unstable fracture. And I've even nailed isolated fibula fractures. Now, some people will argue that it's a stable fracture if it's an isolated fibula fracture without much displacement, and you can let them walk on it anyways. Again, I still don't love my elderly patients even walking in a cam boot. I don't know who has these super healthy 80-year-olds who can just put a cam boot on and hop out of there with no problem. I mean, that in and of itself to me is a fall risk. And so putting some fixation in there, getting them into an ASO brace and letting them walk on it, to me is favorable. But I can certainly appreciate some people that think otherwise. What are your thoughts on I don't know, any of that stuff we just
I think it's the right approach. Do you use tourniquets for these cases or no?
Good question. I always apply a tourniquet. I always put it on. A lot of times I'll try to not use the tourniquet, like not inflate it. I don't know, because you're reaming in this one, you're drilling and reaming, so there's a little bit more bleeding when you start reaming. Right. I don't think I did use a tourniquet on this one, to be honest with you.
Yeah.
It's great. Sorry, getting called by the ER. Of course, they should be tuned into the podcast live, not messaging me about patients in the ER. All right, they can wait an extra 10 minutes. We'll wrap up here soon. Yep. So like I talked about, that jig, when you put that in, you want to keep that straight lateral. Otherwise, it changes the alignment. Don't rely on the nail to reduce the fracture. So I had an episode with Ashley called Surgical Misadventures. And if you want to go back and look at that one, I have some videos and some intraoperative images of a fibular nail that I tried to do that was causing worsening displacement of the fracture because I did not have any reduction on the fracture. So I mistakenly, when I first started using these, assumed that the fibular nail would perform the reduction of the fracture. It does not. You need to reduce the fracture before you put the nail in. And at some point, if you start having to do too much incision, too much reduction, too much this, too much that, it doesn't make sense to do a nail anymore. You just, heck, I've got it opened up to reduce it. I'm 80% of the way towards just putting a plate on it and being done. So I kind of struggle with that mentally of trying to keep the incision small. That's the whole reason we're doing the fibular nail, so we can do it through two or three tiny little 1 centimeter incisions and protecting their skin that way. But I think you can make a small couple little stab incisions and get your reduction. I've tried. I've had some posts out there. People have maybe seen about using a syndesmotic reduction clamp, which was this patient where I tried to use our syndesmotic reduction clamp. And to me, I thought that I could get reduction just by putting one tine on the medial on the medial tibia, not near the fracture, but approximately, and then one on the one tine on the distal fibula and crank on it. And it reduced some, but not as much as you might want it to. And so I would say don't rely on the nail to reduce the fracture. You want to open this up and try to get some reduction otherwise. And watch for fibular shortening. So if you don't have any reduction clamp on there, when you insert the nail and you impact it, it makes sense that you have this giant rod going up the fibula and you start impacting it, it's going to cause fibular shortening because the fracture does not have any clamp on it to hold it. And especially if it's an oblique fracture, you're going to get sliding of the fracture. If it's a transverse fracture, maybe not. Maybe it'll get like a little bit of impaction. But if it's a oblique fracture, it's going to want to slide. So watch for fibular shortening, and you do not want that because that's going to change the function of the talus. And we know that the lateral fibula distally keeps the talus from translating that way. Am I boring you? You still with me?
No. I'm having camera issues.
All right. So I talked about the percutaneous syndesmotic clamp. Wire starting position matters the most. Syndesmotic fracture, syndesmotic fixation through the fracture. This is the last thing I want to talk about here for fibular nails. And so typically when I do an ankle fracture and I have a lateral plate and you put syndesmotic system through that, a flexible fixation system, the lateral hardware goes into the plate. So you have the forces of the syndesmotic reduction system spread through the entire plate. Does that make sense? In this, there is no plate laterally. And typically, just by the nature of where the fracture happens to be, it's probably going to encompass some component of either here or here, which is where the syndesmotic holes are. Chances are the fracture is going to involve some amount of this area of the bone, which is why we're doing surgery in the first place. And it's going to happen. There's only going to be one of these holes that's the optimal position for your syndesmotic repair. That one's probably a little too low, so I'd probably aim for this one. And if it happens to be at the fracture, what's going to happen is you're going to put it in, you're going to cinch it down, and because it's at the fracture, it's going to go right through the fracture. It's going to go sit down deep on the metal. So just be prepared for that. That I haven't really found a way to prevent that. It's just the nature of, well, this is the optimal position for syndesmotic fixation. The fracture happens to be there. When I cinch it down to get, compression medially and laterally, it's going to slide right through the fracture and hug up against the bone. And it's not going to feel quite right. You just split the bone laterally. The lateral cortex just split. And especially in these elderly patients, which is who I use these nails in. I don't typically use them in younger people. It feels weird to just cause a split fracture of the lateral cortex right where the fracture was before. So just be aware of that and just be gentle when you put that in.
That's a good pearl. It's always funny trying to use as many adjectives for a device without naming it.
I know, it's so stupid. They should just sponsor us and then we can just move on.
Done and done, right? Make it easier.
Just send us a check and then we can say the name of the thing that I'm trying to describe in as few words as possible. So, all right, that'll wrap up the first semi-successful live version of
once we got going, things were rolling, no problems.
Do you know what it was? It was let me X out of this. there was one simple button on the YouTube stream that says go live, and it's way up in the corner. You have all of this stuff in the middle of the screen. So we're live on our streaming platform over here through Riverside, and I've got it connected through the Keystream, and I went live down here, the record button. But then I have to go over to this screen, and way up in the top corner, there's this tiny little button that says go live. So now I know it's there, and we won't have any issues in the future. So
nice. I'm trying to look on YouTube. Are there any other people logged in that have questions or any dialogue they want to have?
Yeah, it looks like we have about 350 people watching right now.
That's what I was assuming.
Yeah. No, it's 3,000. 3,000 people are watching right now.
Zeros in the wrong place.
Yeah. Oh, it's three. No, it's 3. No, I'm just kidding. It's somewhere in between those amount. Let's see. I have a student saying hi who is going to rotate with me. Hello. Welcome, I guess.
Yep.
Come March. Looking forward to it. And we have a student who said thank you. So you're welcome. So hopefully this has been helpful. I think what we can do in the future is try to get a format where people can ask more questions. So this was our first kind of attempt at Pod Patrol Live, and working out some kinks and figuring out if we can actually stream it to the YouTube. And the chat's open, but I think what we'll do in the future is, if anyone's listening and wants to do that, we would share the link to come into our virtual studio, or you can come to my house. I don't care, whatever. Show up. Actually, go to Leland's house. Well, I'll give you his address. You can go to Leland's house, show up, just knock on. Actually, just go in. You don't even have to knock. Just go in and
my door's
hop on this. Hop on the stream with him. Anyways, yeah, through our Riverside platform, and people can call in, and they can talk and kind of be a guest, almost like a call-in show. Like, I listen to a lot of sports shows. I don't know if you do too, but there's a lot of sports shows where guests will call in, and most of the time they.
Yeah, I mean, I used to listen to Mike and Mike on the radio, and then when they went away, I kind of lost listening to sports.
I listen to a lot of sports shows, so that's the nature of a lot of sports shows, or the call-in. So I think we could do that. Sometimes people feel scared. I don't know, nervous.
Yeah,
I don't know.
Especially when you have 3,000 people tuned in, you don't want to say something stupid, right?
Well, that's true. We don't want to blow it. So we appreciate everyone tuned in live, and we will get this out as an upcoming episode for those who weren't able to join us live. For anyone who is willing, we would appreciate you going to the YouTube, checking out the videos, like and subscribe, leave a comment, talk about Leland's hairline, talk about whatever you want.
Yeah.
Criticize our t-shirts all you want. So we appreciate everyone's support. Yeah. And we do have a couple sponsors now. So I guess that's a sign that we are becoming popular. I don't know.
Kind of legitimizes the efforts a little bit.
Yeah, I think so.
Yeah.
So all right, we'll keep pushing.
Everyone wish Jeff a happy 40th birthday in 2 days.
40. Yeah, I'm not keeping track. 3 days.
Wednesday?
Yeah, 3 days. The big 40. So
that's awesome.
Yeah.
Well, happy birthday.
And you're almost 50, right?
Yeah, getting there.
I guess if you're more than 40, then you're almost 50.
I mean,
like, if you're 40, you're 40.
The next decade, right? I don't know.
Yeah, but if you're like a little bit more than 40, then you're almost 50.
I don't know. Like, I get to the age now where I'm like, okay, carry the one. I'm like, damn. I'm like, almost. Once you're in your 50s, it's like, good God, what is going on?
Yeah,
I don't know. It's all relative.
Decade that goes by. Everyone says that too.
You get in your 40s and you watch college sports, and you're like, damn, those could be my kids if I had a.
You know what's crazy though is every now and then they'll be like, yeah, he's 38, and I'm like, oh my, I could not imagine getting tackled and just, my back is sore getting out of bed now. Not like that freaks me out more. Like if they're 22, I'm like, yeah, that's fine. I could be their dad, whatever.
That's insane.
But when they're my same age or only a couple years younger, I'm like, holy moly, that's impressive.
Like Kelsey's older brother, I think he was in his upper 30s, right? Yeah.
Yeah. I mean, there's always there's always like pitchers go on into their 40s, and Tom Brady was oldish.
Yeah.
Old for a quarterback.
Yeah.
Anyways, we'll wrap it up. Thanks everybody for tuning in, and we appreciate the support. So thanks for tuning in another episode of Paw Patrol with your host, Dr. Jeff Dygus
and Dr. Leland Jaffe.
We will see you guys next time.
Take care.